Welcome to The View on GU, the place to be for translating uro-oncology knowledge to action. Here are your hosts, Drs. Aly-Khan Lalani and Christopher Wallis.
Hello and welcome to The View on GU. I'm your host, Chris Wallis. With me, my co-host, Aly-Khan Lalani. We're here in Las Vegas today at the AUA 2025 meeting. Aly-Khan, we're thrilled and a little bit out of sorts with having a med-onc down surrounded by the sea of urologists. How you feeling?
Lone wolf out here. I have to say it's been pretty cool in the hallways, another packed meeting in Las Vegas, but urologists have all been actually really kind and accepting of this lone med-onc being here. So it's been a lot of fun. And Chris, I'm really glad we could do this together on site. And just coming off the heels of the oral presentations that are relevant to cancer. And I think the huge focus today was obviously early stage or non-muscle invasive bladder cancer. We have a lot of abstracts to go through, but why don't we level set for our listeners and viewers? And maybe you can just take us through what we mean by high risk non-muscle invasive bladder cancer. What does that mean? And then we can walk through how we would standardly treat these.
Yeah, so let's sort of set the context, as it were. New diagnosis bladder cancer. The vast majority are non-muscle invasive disease that is superficial, either in the lining or connective tissue within the bladder before it gets to the muscle layer. Predominantly these days in the context of the urologist for care. We're going to see in our discussion a role for multidisciplinary care, but right now this is really a urologist-driven disease space. And so just to sort of think about this, not every patient with non-muscle invasive bladder cancer has the same sort of oncologic risk. And we think about things like the grade, the stage, multifocality, and size to help us sort of characterize the aggressiveness of a patient. So we break it down into low, intermediate, and high-risk disease. The vast majority of the data we're going to talk about really focuses on that high-risk disease subset. So here we're really talking about anyone with T1 disease. So that's invasion into the lamina propria underlying that initial mucosa of the bladder. We're looking at people with high-grade histologies. We're looking at any CIS. And then there's a bit of variation between the guidelines, to be honest. There's CUA guidelines, American guidelines, European guidelines. We look at the high-grade superficial, the TA high grades. In some cases, these are all considered high risk. Sometimes we think about multifocality, size, or recurrence to really classify them that way. But really, at the end of the day, T1 for sure is high grade. CIS for sure is high grade. And for most of us, we would tease out that TA high grade and thinking about larger tumors, multifocal tumors, and putting those in that high risk subset that really is at high risk for both disease recurrence after initial treatment and also progression to muscle invasive disease. And those are obviously the endpoints we're trying to avoid.
And you've mentioned it, but what's that role, the presence of CIS mean to you in this non-muscle invasive setting? Maybe just in terms of what you'd expect to see at a population level and how that might influence what you do.
Yeah, absolutely. So CIS, just to be clear, is high-grade cells, not in a sort of a papillary formation, but in this in situ sort of flat a lesion along the bladder wall. It's really a high-grade and aggressive subtype of bladder cancer in many ways with a worse prognosis than a T1 high-grade, even though it's just superficial. We can see it both concomitant with papillary disease or on its own. So CIS alone is relatively uncommon, somewhere in the 10-15% of patients. But then the higher grade papillary lesions often have that concomitant CIS with it. And really we build both of those cohorts together when we look at many of these trials.
So let's go through standard of care, just what we do now around the world in general. Take us through BCG, what we mean by induction maintenance, what you consider, kind of true evidence-based protocols for treating high-risk non-muscle invasive disease.
Absolutely. So, to start, of course, we're starting with a TURBT. And so that's both initially diagnostic and also a therapeutic intervention. And so we know with TURBT alone, patients who have this high-risk NMIBC are at risk of both recurrence and progression. Those are the endpoints we're trying to avoid. And so to do that, we're using an adjuvant approach, ideally resecting as much disease as possible, but then giving intravesical therapy. For papillary disease, we're trying to prevent recurrence. For CIS, we're trying to really induce a full response. And so for patients with high-risk disease, standard of care for BCG would be upfront induction. So that's 6 courses over 6 weeks, followed by 3 years of maintenance. And that's based on the SWOG LAM protocol. We've been doing that for, a few decades now For patients with intermediate risk disease, we think about a little shorter durations of maintenance, maybe more like a year as opposed to 3 years of maintenance therapy.
And then in terms of the BCG, we just came out of an era and some places are still dealing with shortages. So even as a medical oncologist, I know a bit about the TICE and no TICE strains or types of BCG. So does that matter, do you think, overall pretty equal? Because as we're going to interpret some trials, I'd be curious to know if the type of BCG matters.
Yeah, so there's a variety of strains of BCG. I mean, just to be clear, BCG is that form of tuberculin bacteria. Like we're really talking about a live agent, and you could just have different strains grown. Most people treat them relatively interchangeably in clinical practice these days. The real answer is we don't actually know. There's a trial going on called EVER, which is comparing 2 different strains of BCG in a non-inferiority fashion. We're going to have some data. For now, really with BCG access issues, it's been whatever you can get your hand on. I think most people are using, but certainly Tokyo and TICE are probably the 2 dominant ones right now in current practice.
Okay, so this is a great segue, I think, into the major phase 3 trial that we heard about. And why don't we just get into the data? So let's first talk about CREST. This was a phase 3 trial, a 3-arm trial, again, high risk, non-muscle invasive bladder cancer, where a standard approach, as you said, would be TURBT with BCG induction and maintenance. So again, these patients were by definition BCG naive, randomized 3 arms. So arm A was an intervention arm with seslanimab. This is a subcutaneous, so pretty exciting, PD-1 inhibitor given 25 treatments every month or Q4 weeks, so essentially 2 years worth of treatment, along with BCG as the way you've described it. There was a control arm or arm C, which is the standard of care as you've described it. And then there was also an arm B, which was just BCG induction without any maintenance along with the seslanimab. So maybe trying to shoot the shot to see, could we avoid maintenance? So these were 3 arms. Largely, we were looking at arm A versus C, but we had some data for B. And then these patients could have been or having CIS as part of their disease presentation, and that was a stratification factor. So maybe just off the start, take us through the population.
Yeah, so I mean, if we think about this is a pretty typical looking bladder cancer population, right? We're thinking older men in general, right? So we're talking, mid-70s is general clinical trial or clinical practice population, often a little bit younger in the clinical trial world. That's, we know, across disease sites, that's a thing that happens. We have a balance here of the different ways you can get into high-risk disease, right? So we see T1, we see TA high grade, we see some CIS, some pure CIS, some concomitant CIS with papillary disease. I think across this trial, my overall takeaway would be that this is, perhaps not surprisingly from a 1,000-person trial, a pretty representative cohort. So I would say, when we look to take clinical trial results into clinical practice, this cohort to me is pretty representative, and the investigators have done a pretty good job of capturing a valid and actionable high-risk bladder cancer population.
Okay, so Q3 monthly cystoscopies and cytologies as part of care on a trial, 55%, as you mentioned, T1, 25% had some component of CIS, which from the way you've started this whole discussion with us sounds like pretty standard. And then the pure CIS was about 15%. So we had a median follow-up of about 3 years. Arm A versus C, EFS. Maybe just describe what that endpoint is and then take us through results.
Yeah, so I mean, I think it's important, especially for those who are maybe not in the localized space so much, to think about what are important endpoints when we think of localized disease. We think about this in prostate, we think about this in bladder, right? You can't necessarily wait for OS maturation to act on these agents. And so we have to find earlier but relevant disease endpoints. And so when we think about bladder cancer and non-muscle invasive bladder cancer in particular, the 2 endpoints we're trying to avoid, obviously while keeping patients alive, are disease progression, which would be progression to either metastatic disease, which can happen directly from non-muscle invasive disease, or progression to muscle invasive disease, or high-grade recurrent disease. And so those are really the 2 endpoints we're looking to avoid with our therapies. And so I think those are really important and valid endpoints to have as the study endpoint here.
Okay, so what did we see from that A versus C? So this is the seslanimab with induction maintenance versus the standard of care induction maintenance BCG. What's that big take-home data?
Right. And so, I mean, I think, the big number, if you like it, is the hazard ratio. Everyone, we can debate whether relative effects matter more or absolute effects matter more, but we have a hazard ratio of 0.68 here. So that's a 32% risk reduction in terms of that aggregate endpoint of event-free survival. And so take that at some benchmarks. You look at like 2 years, we're talking 85 versus 80%, so 5% absolute relative risk reduction. We look at 3 years, we go 82 versus 75%. Now we're talking about a 7% absolute risk reduction of disease, high-grade recurrence or progression. And I think really when we break down the components of that, we get into where the real meat of the differences are, and that's in that high-grade recurrence. And so this, in the intervention arm, when you're getting the IO therapy, is at 7.5%. And if you're getting just standard of care, it's about 15%. And I would say, honestly, the standard of care here is performing pretty well compared to what we've seen in prior data. To have a 15% high-grade recurrence rate in these patients, I think is pretty reasonable. This is a pretty valid and I think externally valid comparison here.
Okay, so it sounds like the high-grade recurrence is where you make kind of most of your gains here.
Mm-hmm.
Very briefly before we go into what else we'd want to see, we're fresh off the presentation, and so the Nature Medicine paper is still forthcoming. But the B versus C, so this was the just the induction and no maintenance of BCG along with cisplatinumab versus the standard approach. Event-free survival was not significant, hazard ratio 1.16. But, just in terms of that efficacy, as you mentioned, I mean, those who had, having some component of CIS, I think there was a benefit there that might have been even more pronounced, right?
Yeah, I think it's important to think of, what we're trying to do, right? Papillary disease, we're trying to keep disease at bay, whereas CIS, we're actually trying to induce a response and actually drive eradication of disease. And so it's really nice to see that IO addition give us additional benefit in that CIS subgroup. And I think that also plays out when you look at that duration of CR and that ability to sort of maintain these responses, right? At 1 year, we're seeing 97 versus 90%. At 2 years, we're seeing 93 versus 65%. At 3 years, we're seeing 92 versus 68, which is really telling us that when you add that IO backbone, it's really, really durable in a way that the BCG fades off. And so I think that really speaks to that sort of long-term immunological priming that probably can give us really good long-term outcomes for this patient population that in historical times has been plagued by recurrent disease, right? We have to monitor these patients frequently and for long durations, and it really gives a big burden of surveillance and monitoring, and seeing these kind of positive results, I think will change our trajectory.
Yeah, and I that struck me for the 36-month because some of the things I still want to see, and I think we will see more of CREST at ASCO and ESMO, it sounds like. But how if it is durable, how many patients actually need a cystectomy anyways? We'd like to see that, and then as you say, maybe we won't get overall survival benefit with what we're doing, but it would be nice to know as we follow longer term, at least that muscle invasive and risk of surgery. If we're not going to get OS, which and from the medical oncology world we're used to, but we do need to contextualize a little bit. So efficacy clear. How do patients feel and experience? It looks like overall quality of life wasn't certainly affected, so that's encouraging too. This comes at a cost of doing business, so we'll talk about financial cost a little bit later broadly, and then who's even going to give this treatment. We're going to get to that. But part of what stands out to me doing a lot of immunotherapy treatments and trials is side effects. So just from what we saw, top line data, the tornado plots, the BCG arm, standard of care, a 6%, let's say, grade 3 or 4 adverse event rate. Does that sound right to you? And then comparing that to about 30% when you're adding cisplatinumab, and then just to see what you think. I mean, we're going to get into the immune-related adverse events, which is separate, but off the cuff, treatment-related adverse event, does that sound about right for a standard arm?
So for the standard arm, I think it's believable. I think, in general, you see in clinical trials that things are looking a little bit better than they do once you roll them out into clinical practice. So I think in the context of, trial environment, we've got nurses all over these patients. We've got an ability to early identify and probably intervene in a way that clinical practice doesn't allow. But I think we can believe this. And I'm interested in your take on sort of the IO toxicity in a patient population that is, very early in their disease trajectory for a non-invasive cancer.
Look, a grade 3, what they call IM or IRAE, essentially immune-mediated or related adverse event of around 16%, let's say, in a very early stage bladder cancer is significant. I mean, comments were made that it's mostly thyroid and you can always fix, cure someone's endocrine deficiency by giving them hormone treatment. I mean, again, those were a lot of grade 1, 2, which I appreciate, but some of these grade 3s were, 3% rash. We have hepatitis in 3.4%. I mean, there's pancreatitis at 2. I mean, there's pneumonitis, adrenal insufficiency, again, treatable. But these are things that as we talk about implementing this, I mean, those aren't inconsequential. How we discuss and contextualize this for patients in a incurable stage 4 bladder cancer setting, let's say, and the willingness to accept immune-related adverse events versus what you're used to doing. And, are we even used to checking blood work? I would suspect with BCG or not. So even catching this, I think, is a bit more. But yeah, I think it's going to be a good discussion amongst the community and patients. Is the juice worth the squeeze? And I think if we see this really long-term benefit, of course, patients will say, look, I'll take a little bit of that risk up front. We're used to seeing 2 and 3 drug IO combos have really high or much higher adverse event profiles, but this is not immaterial in situations where clinics typically aren't used to following for this.
Correct. Yeah. And managing it.
And so I think that's going to be really important, but this is encouraging data. I would say this would be, kind of the main oral takeaway from a randomized trial. So that was really important. So look, Chris, you've taken us through the landscape of that BCG untreated patient, and that's where CREST kind of comes in. But there's an important cohort of patients who unfortunately are deemed BCG unresponsive or BCG failure. So can you define that for us, and then maybe take us through what do you currently do in your practice for those patients?
Yeah, so there's a variety of definitions that we will anchor on what the FDA says, because that's how most of the trials have been designed. So the first thing conceptually to think about is for a treatment to have failed, and I like to think of it more as the treatment's failed the patient as opposed to the patient being a failure. You have to have given them enough. You have to have given it a fair shot. So we talk about adequate BCG. And in general, that means 5 out of the 6 doses of induction and at least 2 out of 3 doses of a maintenance course. And so we're talking in general about 7 treatments of BCG at minimum to be considered adequately treated. And then we get into the context of BCG unresponsive, whereby there's disease in spite of adequate treatment. And so, in today's clinical practice environment, the standard of care in our guidelines remains radical cystectomy, which is clearly a big swing for someone who was just diagnosed with a non-invasive tumor, has tried intravesical therapy, which, as we talked about in terms of toxicity profile, doesn't carry a ton, to talk about taking out the bladder and potentially life-changing, if not potentially life-threatening consequences of that. And so obviously people are interested in other ways to treat this that can avoid the cystectomy and spare the bladder. So, in our current practice environment where I practice, we do a fair bit of intravesical chemotherapy. We use combination gemcitabine docetaxel. I think single agent chemotherapy's fallen out of favor a bit. We used to use single agent gem, single agent mitomycin C. Valrubicin is the only FDA approved one. There's a little bit of epirubicin depending on where you practice. Certainly not a Canadian pattern, but for us these days, radical cystectomy is on the table. Gem-doce is probably the go-to option. And then clearly at our site, clinical trials are an option that comes up as part of the counseling for every one of these patients once they get to BCG unresponsive.
Yeah, and so that's a great segue into the other data we saw at AUA this year. So let's start first with the BOND 003. I love that. And then cohort 3. So this was a single-arm, open-label trial using cretostimogene, which targets the RB and E2F kind of promoter pathway. And the thinking is that it can work with tumor lysis in addition to immune activation and really augmenting these patients who, again, are high risk, non-muscle invasive, BCG unresponsive, and have CIS, where this trial would have allowed a second induction, as mentioned. So 110 patient study. Maybe take us through what we saw there.
Yeah, so just to level set, maybe for the med-oncs a bit more than the urologists here, FDA has said the single-arm trials are registration appropriate in this disease space. So just for what it's worth, when all this stuff started evolving, there was, as I kind of alluded to, no real standard of care. And so there wasn't a good default comparator option. And so we have a lot of single arm trials here that have led to registration. So just for what it's worth, that's a thing that's done in this space, although it's not, widely done in oncology. So a single arm phase 3 here is theoretically the appropriate trial design. We see a fairly typical BCG unresponsive patient population. I would say this one's not a remarkable population in any way. Our overall CR rate, so that is complete response at any time during follow-up as measured by cystoscopy, biopsies when indicated in cytologies, is 76%. Now, for what it's worth, historical precedents are like 20, 25%. So 76 is a good number. And I think the real devil is in the details here, right? So an anytime CR, I find actually relatively hard to use for patient counseling. So the better endpoints, I think, come at longer time. So we see 12 and 24-month data here. And so we see a 46% 12-month and a 34% 24-month CR rates. And if you use the KM versions, it's 51 and 42% respectively. And I think that tells you something about not just the ability to induce, but also to maintain that complete response. And so durations of response among responders are like 65% at 12 months, 58% at 2 years. And so, this is a clear improvement over historical standard of care, but still means that I think we do have a lot left to gain for these patients.
Yeah, and to your point, like this would be a treatment that it sounds like it could fit into a urology workflow right now because you're giving this intravesical therapy, the nursing support, all that is kind of well known, and it might provide a backbone for what we're looking at in the future. But then the question is, well, what else can you do? And pretzels are all the rage. We can't not talk about that in NMIBC. So let's just quickly cover the 2 Sunrise abstracts. Okay, so for our listeners and viewers, there was 2 abstracts here. One was looking at TAR-200 monotherapy in BCG unresponsive, high risk, non-muscle invasive bladder cancer with CIS, looking at 1-year durability. We're going to get to that first. And then after that, there was also the TAR-200 monotherapy, high risk, NMIBC, BCG unresponsive, but only papillary disease, which, as you mentioned, is resected disease. So let's start with the first one, the 1-year durability with the CIS component.
Yeah, so let's just to level set here. TAR-200, I think, is in the water enough that people know, but just to be clear, this is a pretzel-like device that essentially slow releases gemcitabine. So as we said before, gemcitabine intravesical, one of the standard of care sort of options here, usually used in combination with docetaxel, but we're using a drug we're familiar with in non-muscle invasive bladder cancer in a different sort of delivery mechanism. And so what we see in cohort 2 here of Sunrise 1, the treatment with single agent, i.e. the TAR-200 monotherapy, is, I would say, a fairly consistent result with the earlier data. And I think that's reassuring, shows us that we get, with longer follow-up, continued good results from TAR-200. So we're seeing an overall CR rate of 82%. Recall, we just talked about BOND-003 at like 76% and historical precedents around 20 to 25%. We see 12-month CR rates around 46%, KM adjusted out to 52, 24-month KM adjusted at 45%. And I think, this is really reassuring data. When we put it in combination, again, thinking about among the complete responders, how do they maintain it? At 12 months, we're seeing 56%, 24 months, seeing 52%. So I think you need to put these 2 numbers together, right? You want to look at the proportion of people who are able to get a complete response and then the proportion who are able to keep that complete response. So it's like a nested probability, right? And you actually have to do this conditional probability to understand when counseling your patient, what's the chance that a year, 2 years down the line, they're actually going to be free of disease. And I think that was a really nice aspect of Dr. Joseph's presentation, was to look at that and compare it to other treatment options available out there. So when we look at TAR-200, again, CR rate at any time, 82%, 12-month duration of response around 50%. That translates to induced and maintained CR at 12 months of around 45%.
Yeah, and I think having at that 12-month mark, 85% of patients cystectomy free, I mean, that's, still, you want to follow that out further, but that's great. And then as you say, to see all of these responses in that first 2 or 3 months is nice, right? That median onset is early. So that's, I think, really impressive. And patients do decline cystectomies. I mean, 96% in that, to get into that study, declined it, but could have been eligible. So let's now pivot to the cohort 4. Again, same kind of setting, except these are patients without CIS, but had papillary disease. 52 patients. So tempering a bit that, 60% were TA, 40% were T1. And again, as mentioned, right, you're giving TAR-200 every 3 weeks up to 6 months, and then every 12 weeks up to 2 years. So take us through kind of what outcomes we saw there.
Yeah, so I think we alluded to this before, but in the context of CIS, we expect disease to be there after resection, right? We're not going to get all the disease out surgically. And so we're looking for a complete response. We're looking for the treatment to induce a response for us. Conversely, in the papillary-only disease, surgical resection should remove the disease. And so there should be no evidence of disease. And so we're looking to prevent recurrence rather than induce a response. So CR is not the endpoint here. We're looking at disease-free survival, which functionally means recurrence-free survival. And so we need to think about the outcomes a little differently and think about how we evaluate the treatment efficacy a bit differently. And here we see really early data, right? This is 12-month median follow-up. So we have DFS reported only at 6 and 9 months. We get 85% at 6 months, 81% at 9 months, which I think are promising, really interesting results. We don't have a great standard of care to compare to here. We don't really have a great historical precedent. All the FDA guidance was in the context of CIS. And so, I think this is a bit of an evolving disease space, and we don't have great comparators. So, I think this is promising. I think it's early data in small cohorts, but a patient population that is in need of new treatment options that are allowing us to spare their bladders.
Yeah, I know. And I agree. And we probably should, in the last few minutes of our podcast here, come back to a little bit about how we're going to roll out things like potentially IO therapy in this space. But maybe just a quick summary on another oral abstract, the CISTO study, which was trying to answer this question of radical cystectomy or bladder sparing approach in recurrent high-grade non-muscle invasive bladder cancer. That's kind of what we're trying to use drug therapies to avoid. But this was a prospective observational cohort, some quality of life endpoints, maybe a quick summary on that.
Yeah, so to sort of keep it short and sweet, the context of the trials we've just discussed are essentially in recurrent high-risk bladder cancer among patients who don't want to have surgery, with the sort of implication there being that the guideline recommendation is to have surgery, to have your bladder out. And so the comparison here in an observational non-randomized way is, what happens when people try to spare their bladder with intravesical therapies, essentially, a little bit of IV pembro in this study, or they just have their bladders out. And so, an overall primary outcome measure here is physical functioning. In general, that wasn't really different between the two groups. There's some trade-offs to be had. If you have surgery, your bowel and sexual function takes a bit of a hit. Conversely, the surgical patients tend to do a bit better in terms of financial toxicity, in terms of mental health and cognitive effects, and have a bit lower recurrence rates. And so, I think that that trade-off is part of that standard clinical interaction in our clinics every day, where we can get a bit more oncologic certainty, i.e. reduce that recurrence rate, but at the sacrifice of some toxicity. And I think that's what we can take from CISTO, I think, at this point in time.
So look, at the time of this recording, we're fresh at AUA. We don't have, obviously, FDA approval as of yet for using something like seslanimab in BCG naive patients. I think time will come for that review. We're on the heels of further data coming, other PD-1 and PD-L1 drugs already being studied with BCG in that exact context. We're waiting for that. And then, oh, by the way, you've mentioned the TAR program. There's Sunrise 3 and other programs looking at TAR-like agents in this BCG naive setting. So this is clearly one of many. We may not have that perfect answer today, but let's just think through this a little bit, Chris. So we talked a little bit about this off camera, but rolling this out in real time. So options are the urologist's scope has to change, and everyone needs to get used to giving subcutaneous immunotherapy. And that's going to need probably a generation or shorter of changing training programs or uro-oncology fellowships to make sure everyone's ready. Reality is we're probably going to get FDA approval sooner or HTA review sooner. From your perspective, and I'll certainly give my take, but who should be giving these patients 2 years of subcutaneous IO?
Yeah, so I think we need to take a half step back. A lot of the stuff we talk about where we say, oh yeah, the urologist or the rad-onc can do it, in high risk prostate cancer, this is a subset of urologists who do these things, right? Like not everyone's taking out prostates or bladders. TURBT and non-muscle invasive bladder cancer is not a uro-oncology disease space. This is a urologist disease space. The vast majority of urologists work here. This is not a subspecialty sort of focus necessarily. And so I think when we think about these patients are seen by the vast majority of urologists across our jurisdictions. And so this is a very wide-ranging, very heterogeneous group of patients, heterogeneous group of physicians treating them. I think the notion that the average patient today who's getting BCG is getting seen in a clinic that is willing to take on sub-QIO is not realistic. And I also think the notion of centralizing all these patients into uro-onc centers is probably also not realistic. And so we have to think about how we roll this out. Our community med-oncs going to need to step into the non-muscle invasive bladder cancer space. I think it's something we have to talk about. I think it's probably more realistic to keep patients getting treatment close to home than it is to bring all these patients into subspecialty uro-oncs.
Yeah, and we're going to have some institutional learnings when we have, subcutaneous or other approaches of IO delivery already in, let's say, hopefully for adjuvant bladder cancer treatment with subcutaneous Nivo. And there's going to be already data in head and neck for pembrolizumab, so that those approaches. So I think it's coming, but I agree with you who actually gives it, knowing that, it's not just incremental cost of saying, let's do blood tests in a urology practice to look for IRAEs. I mean, this is a new ad. Then the monitoring, then the dealing with it, and then simply saying, well, your friendly gastroenterologist and endocrinologist who's at your fingertips. Well, does every urologist in the world or Western world have access to specialists outside of academic centers or who do these clinical trials? No, right? So I think simply saying it's going to be a wash that everyone's going to be able to treat tomorrow if the lights go on for this treatment is too simplistic, but it is definitely going to change that whole funnel of patients who never would have needed an IO, whether it's IV or subcut, is expanding. And so we need to be ready. And there's more and more then in the community experiencing this. 15% grade 3 immune-related adverse event, now putting that into non-muscle invasive setting is very different denominators than what we had for muscle invasive or even metastatic disease. So,
well, realistically, for many clinics, you're thinking like 1 in 6 at 15% means like probably a couple patients a week.
Yeah.
That's a lot of toxicity for a urologist to
it's why we do this podcast.
Exactly.
I mean, we this is multi-D and we kind of saw where this landscape is going, and I think it's perfect to have this conversation. So this has been fun. We do have to get back to the AUA, but Chris, hopefully we'll both get some downtime here and some personal time, but it was really great we could do this. To our listeners and viewers, thank you so much. A lot of people stopped in the hallways to say how they're feeling and giving us ideas about other topics they want to hear about. So please hit us up on socials. Let us know what you'd like to hear. But for my co-host, Chris Wallis, I'm Aly-Khan Lalani. Don't forget to rate, review, subscribe, and we'll be back with you again, signing off from AUA 2025.